Melody's back. We're back on the trail here. Who are you, Melody, and what do you do?
It's Melody Bishop RT. I'm here trying to explain the squiggly lines on the vent.
Mm.
And how about you, Nick? Who are you?
Oh my God, who am I? These days, I'm sort of maybe given recent takes the most widely hated man on ventilator Instagram, which I like. So I'm good with that. That's usually where I like to be. But I think two things. One is because of what you've said and shared and done as far as from the dysynchrony standpoint slash space, and then probably my recent sort of foray into RVC and how it's not a great mode because when patients start to work, that it starts to support the patient less and less. We thought this would be a good time to talk about flow starvation.
And I love that you're introducing flow starvation as a term first, because I think this is one that people understand. But really, I like to term this type of dysynchrony that you were dealing with as more of a support starvation. That's what I
Okay,
like to say, because depending on the mode you're in, the patient might be able to pull a lot more flow, aka
right,
any pressure breath. So it
right,
really doesn't necessarily start as a flow starvation. So I like to
right.
say support starvation. We're just literally starving our patients for the support that they are asking for every breath.
Now, so when we say flow starvation, do you think that just a general RT slash intensivist will think that that means that the patient just needs more flow? Do you know what I'm saying? Is that what, do you think that's a problem maybe with how we define these things? Is that if the flow was X and if we just made it more, then everything would be fixed. But in fact, it doesn't always, just because the flow maybe on a PB is, I don't know, 50 liters per minute or so, right? And we make it more to 70 or 80. That doesn't necessarily mean that it's going to help the patient with his or her work of breathing. Is that right? Do you agree with that, or do you think that's totally off base?
No, I think it is right. And I think that part of the problem that I have with terming the problem of not enough flow or saying flow starvation is that depending on the mode of ventilation you're in, a lot of clinicians at the bedside are then, well, I can't change flow directly. How can I help them with flow starvation? And then to be able to look at what you're seeing and then decide what is it that will give the patient the support they want when you can't necessarily change flow directly. And terming it just flow starvation in a mode of ventilation like pressure control or PRVC, where you're not setting flow directly, then people might be like, well, I don't have to worry about that. That's not something that my patient's going to have to deal with, but it still is going to occur sometimes depending on how you have your settings.
So you're saying that in pressure control and PRVC, you don't set the flow? But I thought PRVC was just it's volume control. It's pressure regulated volume control, Melody. I don't like. What do you mean? It's not like.
Are
What
we
do you
doing
mean you
this
don't
on
set?
the right?
Yeah, why not? That's right. That I've gotten many angry DMs from many angry people that it's volume control. And that's when I ask that question, that's so oh, it's PRVC, pressure or volume? And most people sort of think about it for a second and they're like, it's volume control, pressure regulated volume control. And I'm just like, so it's not volume control because as you point out, the flow is the thing that's independent. So in pressure modes, flow is independent, which it is in PRVC, which is why I think honestly it's one of the more dangerous modes in a lot of ways. I know I sort of talked about this a lot, but the reason why I think it's so dangerous because at least with volume control, you're sort of limiting the amount of volume the patient can get in a breath. Now, if they double trigger or whatever, that's a different story. But outside of double triggering, under supporting is a whole separate sort of topic. So just leave that off for a side. But with PRVC, you can be both under supported, but also pulling more volume than you should be pulling if you're worried about adhering to a low total volume strategy, which is why I think PRVC is certainly, I just think it's the most dangerous mode in general because it sort of lulls you into being sort of complacent as you think that, oh, well, the vent's not dinging, it must be fine. But in fact, it's much worse than you thought. You know what I mean? So flow starvation, while simple terminology probably is too simple. So one is like sort of a flow starvation, but the other thing is the patient under supported. These things can often go hand in hand. Sometimes maybe they don't go hand in hand. The patient can be sort of supported well, but want more flow or vice versa. So then, as you brought up, the next question is, what does it look like on the ventilator? And does the mode matter, I guess? Does it matter? What will the flow curve look like on each type of mode?
And I think what you just said there is super important. A lot of things you just said there were super important. And I could talk about my agreement with you on PRBC all day, reminding the world that it is a pressure breath. And I like to teach, and this is a bit of a sidebar, but when I teach ventilation, reminding people that at the end of the day, there's four different variables that are affecting inspiration. You have the pressure applied, the volume that's going to happen. You're going to have flow being used to achieve those two things and
Right.
time that is going to be occurring. Those four things are happening when you have a closed system and you are pushing air into a lung that is going to stretch. And
Hmm.
you can't control it all. And essentially, whatever mode you're choosing, you are choosing what you're controlling. And
Right.
when it comes to PRVC, you are trying to control more than one thing. But with that, there is so much risk on the other end that the patient is then potentially not going to get the breath that you want them to get because you're trying to inflict mixed controls. And you always say, allowing the ventilator to then make decisions and change them to breath, which
Right.
always introduces a lot of issues. So I'm with you on that, in the fact that PRVC can be a very dangerous mode, especially when you have a spontaneously breathing patient. If they're paralyzed, then I think it simplifies that mode a lot. But with a spontaneously breathing patient, I don't use it. That's
Yeah.
my own.
And I know it's funny you say that paralyzed because I've done this a few times to see how much. So if the cell is that you get the volume for the least amount of pressure or whatever they sort of say. I toggled back between DC and PRVC if someone's been paralyzed to see how much pressure it's saving me. It's the difference between like an inspiratory pressure of 19 and inspiratory pressure of 21. Is it really that much better? 2 centimeters of water. Does that really make a difference? Does it matter? Is it worth? Is the juice worth the squeeze when that patient wakes up and starts breathing and then things really get off the rail? Because I think, and maybe you can attest to this. Do you think most clinicians are comfortable with identifying abnormal on volume control as opposed to pressure modes, pressure control, pressure support, PR, whatever it is?
I think it comes down to where you work. If you work primarily with pressure modes, I think your knowledge of what normal looks like does definitely greatly increase.
Yeah,
But I know for myself in my current practice, working with the
right.
T1 as the primary ventilator that we use, that only,
Oh, we love the
but
T1.
I
I
bring
know,
this up
right?
on purpose. I bring this up on purpose because your options are pressure control or PRVC for your control
Right,
modes. Those are the only two choices you have.
right.
And inevitably, no matter what, all clinicians that first learn that ventilator want to go to PRVC because it's so easy. They can set a volume. It's so easy.
Right.
But within a very short period of time, once we introduce pathology and when we introduce the next level of ventilation, I would say 99.9% of all people say, oh crap, PRVC has a lot of problems and I don't really know what it's going to do. I'm going back to pressure control because I understand this more. So I have found that all clinicians, when given the option, when shown how one works versus the other,
Yeah.
specifically with pathology and lungs that get sicker and sicker, they all default to less control for the vent, more control for me.
Right. Is that what you mean? Got it. But the thing that's interesting is that at least with Hamilton T1 or in that sort of arena, which I'm assuming you're pointing out either pre-hospital people or transport folks, most of the patients they have are sick, right? More or less. More the reason, so I give PRVC a pass if because a lot of the nursing homes around here, so Melody's in Canada, I'm currently in Baltimore. I don't know how Canada is as far as like the nursing home folks, but in America, there's these long-term care facilities that take ventilators, people have trachs for whatever reason. And a lot of the vet places like to have people on PRVC as their mode because I guess they think there's an added safety benefit or something to that sort. So I have no qualm with nursing home person here for urosepsis, not sick, not in ARDS. If they want to keep them on PRVC, I don't change. I don't upset the apple cart in that way. But using it as a primary mode for sick people with other pathologies, I think it's not applicable. So for pre-hospital folks or people transporting sick patients from outside hospitals to tertiary coronary care centers, I can't imagine there'd be a good patient that would be good for PRVC. You know what I mean? So sure, if you're transporting some nursing home person for a procedure, then sure, go for it. But I feel like a lot of patients are going to see probably not going to qualify for RVC to be sort of hands off. You know what I mean? And then you're
Yeah.
switching to pressure control. Then it's like, I don't know. Then you're trying to sort of catch up. And then because the problem is when you are on PRVC and the patient's pulling, the ones that I always A send to you and then B post, as soon as I switch them to pressure control, because of how much they're pulling, they pull a massive volume for the first couple of breaths, probably for 15, 20 minutes. Then they sort of chill out. But you got to ride through seeing a ton of volume of 800,
Yep.
which I am not married to the 6 cc's for everyone, Dick. Certainly not for patients with COPD. It just doesn't work. We've seen this time and time again, especially with PRVC and PC. It just doesn't work tying them to 6 cc's because they have too much dead space and then they start breathing fast and then they get auto peep and then things just really fall off the rails. But so I don't know. I think there's not that many situations for us at least where PRVC is going to be applicable mode, even for a lot of people. I don't know. That's what I think. But nevertheless, so it sounds like PRVC pressure and volume have different ways that either under support or flow starvation in air quotes will look like. So you sent me this to the left, like this figure, which is from a review article, which I guess I can link the article when I post this. It's actually not, it's an article I read before. It's a well-written article. The people from UConn wrote it. Foley is one of the guys, and Brandon Odo, who I mentioned, I know he's from critical care scenarios. But anyway, so this pressure one really wasn't showing starvation per se, but it's sort of applicable. What they were highlighting was the delayed cycle just here because the patient starts to push up. Now, I will say for pressure control and pressure support, those things often go hand in hand. If the vent's sort of behind the patient time-wise, so you might have to tinker with the TI because they're going to pull this big volume. Then probably right around here, they start to push out aggressively against the ventilator to get it to cycle as Melody, I'm sure. But we'll reiterate that in PC, the I time we set in PS, it's the decay flow. So a lot of times we see this in patients with COPD where they might want to breathe faster. And if your TI is too low, 25%, when they get to about here, they'll start pushing out against the ventilator to get the cycle. It's sort of a subtle, I think, synchrony. It's not sort of like overtly. It could be sort of definitely more overt, but this is one of the things that I look at and I'll often tinker with the cycle decay in order to make the ventilator fit the patient a little bit more. But
I think before we get too involved, I think this is a really good slide to have side by side because actually, yes, even though the article is pointing out the delayed cycle here, looking at it now with eyes, you can see crazy work shifting, which is the term that they're going to use on inspiration and expiration, specifically expiration with the pressure control waveform on the right. So I think one thing to kind of talk about here is that when we're talking about patients that are working hard, the thing that clinicians have to do is they have to know what normal looks like. And so on the left here,
wonderful.
we have volume control. And then on the right, we have pressure control. And without even knowing the modes, I can tell it's what we're looking at for multiple things, which I think we're going to get into. But
Yeah.
then when we're dealing with a patient who's not getting support in each of these modes, our eyes should be looking and drawing to different waveforms depending on your mode you're in. And in
Hmm.
volume control, which is currently on the left side of the screen, knowing that flow is usually controlled by us, you can see we have a very linear decay in our flow waveform, in our volume waveform, in our volume, in the volume control options. Our flow is very linear. This is controlled. This is machine when it's so linear like that.
Right.
So I'm not going to get much information from that inspiratory flow time waveform because it's controlled. I'm going to see a lot of information on what my patient's doing in my pressure waveform and volume control versus in pressure control, where the pressure is the thing that we're controlling. The pressure waveform might not give us as much information about how the patient's doing. We instead should look at flow because flow is the thing that varies in pressure control. So just to back up there before we get into the specifics on these two different modes, but just for a clinician that's starting, know what normal looks like. And that's the first thing. And then also know where you're going to look to see what your patient's doing. Over to you, Nick. What do you think about normal and what normal looks like for these two modes?
Oh, I think my stance to this day, how I teach it and what I do is take pictures of the vent. If I don't know, I take pictures of the ventilator and then draw what I think normal should be and then sort of backtrack. What am I seeing? What's abnormal? So you're right. So what one person told me before was for VC, if you want to know what the patient's doing with the flow, you look in the expiratory waveform because that's unfixed, right? The patient's going to be, they can
Yeah.
either be along for the ride or doing stuff, having ineffective trigger, blowing out because they want it not in an exponential decay of the flow.
Yeah.
So that'll give you information. You're right. Looking at the in-story limb of the flow in VC is useless because we set the flow. So it's either going to be a decel ramp, so usually to zero, sometimes not, depending on the ventilator, or it's going to be square, right? Now, if it's square, then your pressure waveform is going to look different. What you have to do is look at the pressure waveform to really see what the patient's doing and actually see what you're missing in the sense that we brought this up. I brought this up with my student this week was because we're talking about worker breathing. So if this is normal, right, the first one's normal, and this is abnormal, which they sort of highlight, the thing is that the pressure that's missing, which I like to shade in, and I'll try to shade in pink, and I'm using my trackpad, so it's not going to be beautiful, but this is all pressure that should be there that isn't there.
Mhm.
So if the ventilator isn't giving it, then where is it at? And yeah,
Yeah.
where to go? So where it is the patient's providing that pressure by dropping his or her diaphragm
Mhm.
to get the volume and flow in. Then, unfortunately, when you come to something like this, it's even more pressure that's missing. All this area under the curve of pressure is pressure that should be there that's not there, that the patient's not providing. Be there, that's not there, that's black. I didn't mean to do that.
So you look in your pressure
And
waveform.
and so the other thing is the last part of this is where the patient's active, is where they're pulling in, right? So you don't like you could if you wanted to, you can under here draw what you think like esophageal probe would show you. So here, the patient would be pulling in, then at some point they would stop, then they wouldn't do it anymore, and then they would pull in again. It might be more. But I think the useful thing about this exercise is that when you shade this area in, that is work that's being done by the patient. So you can quantify how much work the patient's doing, number one. Number two is with certain ventilators, Turbo is one of them. I think if you plug the esophageal probe into the vent, it gives you a worker breathing number based on the esophageal manometry. So you can actually quantify how much work the patient's doing, which is important because especially in weaning modes, or weaning, sorry, not weaning, especially in
Nava
like
and
doing,
Pav.
but not so much on PAV. What I mean is that if you're using that and you are doing a pressure support trial, you can quantify the joules, and there's like a certain amount of joules that will predict failure, which is a very specific way to know if the patient's going to fail a weaning trial, which I like personally. I don't use it a lot because we don't really put a lot. I can't put in. I don't have esophageal probes in where I'm at currently to use, but in fellowship we would drop probes all the time, and we'd be able to quantify how much work the patient was doing, which I thought was interesting, and it's
Mhm.
helpful, right? It helps to know. You know what I mean?
Yeah, for sure. And I think to simplify the volume control pattern for people, normally when I explain it, remembering that we are dialing in that fixed peak inspiratory flow, and then that flow is going to slow down throughout that breath. And the vent is calculated with X volume that you have put in volume control, with X amount of time, this flow will achieve that volume. So that's what the
Right.
vent has done in the background with what you've said. So then with that, you have a finite amount of flow. And if you think about a patient who is, it's a closed system, right? So the diaphragm then starts to pull. It's going to take all that flow and burn through it and then start to pull bias flow, start to really work. And so what you're going to see with that is that the overall pressure in the circuit just disappears in a fraction of a second as that diaphragm has pulled. So we're not pressurizing anymore in our pressure waveform because the diaphragm has pulled so actively. So that's why you're seeing that negative deflection and it gets bigger and bigger for all of those that this is still new to. Just think about having a finite amount of flow that you could breathe in, and then you're sucking back against nothing, like a closed valve. That negative pressure in your chest is what we're seeing in that deflection. That's kind of how I try to explain it for why we see what we see when the flow gets used up in volume control. And this is true, what I term flow starvation.
What is bias flow?
I think we did talk about this a little bit, but essentially it's extra flow that is running through the ventilator circuit that's always there. So it's on top of a breath being delivered is going to be on top of that. The bias flow is always in the circuit and it's used to ensure that it can sense patient efforts. It's used to ensure that it's maintaining the peeps, and usually that extra bias flow is modulated with your expiratory valve. Essentially, it's just ensuring that that circuit is always under pressure because when we are applying positive pressure ventilation, regardless of inspiration versus expiration, we are always applying some type of pressure to the lung to restore their FRC. So even during exhalation, it's PEEP. So that bias flow is how the vent does that. And then also having something in the circuit that's moving that it can then sense patient efforts off of that bias flow if they're pulling an effort. I hope that was a good enough explanation for you, Nick.
That's exactly, no, that's good. And that's important to know that if you're getting into that much work, the patient's doing a ton of work. And it also is important to know that that can happen when you're really sort of worried about how much volume you're delivering. The patient's pulling more flow than you're really allowing because of how hard they're pulling on that circuit. That's when it's not impossible to pull more, well, get more flow or volume. Even if you're in volume control, you think you're controlling it tightly. You might not be controlling as tight as you think, I guess is what I mean. So
And
go ahead.
I was going to say before we move on to pressure control, what I
Uh-huh.
wanted to pose to you, Nick, and have you explain is I think trying to explain to people why this is so scary, why seeing this negative deflection in your waveform is so scary when it comes to the lung and lung health and damage to the lung. If you were to explain this to a layperson of a patient who is spontaneously pulling and causing this much work, what is your concern as a very well-established pulmonologist with a
Mhm.
patient that's working this hard when it comes to their overall lung health and maybe thinking about ARDS and that stuff?
I think a few things. One is from a top down, it's torture. Essentially, we're torturing the patient, number one. Number two is it's not helping them. So if, let's say they have ARDS, so if that's zero, so let's say that's a negative 4 or 5 or something, and so they're pulling the vent circuit to -4. Think about what their transpulmonary pressure is. Their transpulmonary pressure is probably -20 or something. So it's incredibly negative. This is where we get into this discussion of like, he's silly. So it's like patient-induced lung injury, where you have these wild swings in your transpulmonary pressure from the diaphragm dropping down aggressively. So causing a lot of shear force on the alveoli, certainly causing sort of adduct trauma, certainly, which propagates ARDS and sort of all the quote unquote badness that we have. Not to mention that it doesn't help. You probably have local overdistension of some alveoli as you pull harder and harder, where others are not opening at all. So you're not in a state of sort of applying pressure consistently to open up alveoli and the torture aspect. Number two is this P. silly thought. Number three is just diaphragmatic trauma that plays a big part in ICU patients. Why can't patients wean get diaphragmatic trauma sort of pretty fast, certainly fast from just from being started on the mechanical ventilator. It happens quick within hours. So especially if you get it just from that, and then you have this on top of it, you're setting the patient up to have a pretty rough go on the vent to begin with. So
I think that was so well said because I think this is here. This dysynchrony is why I am passionate about dysynchrony. Just like what you said, everything that you just said, this dysynchrony is where everything, it all comes together and it all matters. This is the thing that is going to harm your patient more than a zero flow hold in your inspiratory time.
the thing that we talked about a lot, or at least I do sort of ad nauseum, we said this a bunch of times, is like you need to know normal before you can identify abnormal. We talked about that. So if you look at like again, I'll reference like the Cleveland Clinic paper from their group, and they sort of really discussed this in like the sort of work shifting like terminology, not so much flow starvation per se, because I guess can you exist in a world where this flow, whatever it is, is adequate? It's just that like it's not enough pressure per se. Like, do you need more pressure? Like, and if you supplied more pressure but didn't really change the flow, would that be okay? That's one question. The second question is, so for volume control at least, for we can sort of I think easily identify work shifting with this volume control, but then like with pressure control, why does it really sort of fall apart? So the first thing to know, I think, is that patients, so like worker breathing on the ventilator, ideally, the way that we teach at least, and like I don't know, Melody, maybe you guys like you like think of it differently. When we talk about worker breathing, we think that the the um the best worker breathing percent, let's say, is just like the trigger work that's done by the patient. So if the patient just triggers the ventilator and then just goes along for the ride, that's the best. That's like the best of both worlds. We talked about how if you do too much work, you diaphragmatic trauma. If you don't do enough work, your diaphragm gets really thin and atrophied. Like how much work is the appropriate amount? I don't know if there's really like a specific study or something that like delineates that. But when we talk about worker breathing, we say that we want the patient to at least trigger the ventilator, sort of like do that work, like the trigger work, and then more or less sort of be passive in like the back seat for the breath, at least during like the acute disease process, like ARDS, whatever it is.
I was gonna clarify that like
Yeah.
we're talking here specifically that we want the patient to be more passive in the acute phase. Like I think
Mm,
once the patient is on like the up and up and we're getting better and
yeah.
resolving and you are actively in the process of now we're rolling back support, then you want them involved, but you don't want them overworking. And I think
Right.
like this whole movement towards like from flow starvation to work shifting is kind of that understanding that like when we're talking about an an unequal amount of work that the patient is doing too much of it, like that would be how
Yeah.
I would describe it, Nick. Like how would you describe this new understanding of the term work shifting to kind of encapsulate too much work by the patient?
Yeah. Unfortunately, and hopefully, I know Melody always wants something like brilliant for me. I'm so dumb that it's a shame. So I just think of it like shifting the work. So we're shifting the work from the vent to the patient, right? So this is work that should be here in the red that I'm sort of like highlighting. So we just shifted that to the patient. The thing to identify is that as this gets worse, you're shifting more work to the patient that the vet is not doing that now the patient is doing. Does it really bother me that much if there's like just a little scooch of a divot right there? Like it doesn't really bother me too much, right? Like that at least tells me the patients do a little bit of work. I think when it starts to get, and you can sort of quantify this, just like you can quantify when you did like the cycling stuff. You can quantify premature cycling, sort of like mild, moderate, severe. Severe is a double trigger, right? If you have severe premature cycle, that's a double trigger, because the patient pulls down so much that they trigger another breath. I look at work shifting in the same way. You can have sort of like mild, moderate, severe work shifting. Mild work shifting would be something like maybe that I drew. There's a little bit of a divot in the pressure curve, but overall, it looks like the ventilator is doing most of the work, providing most of the pressure. As the divot gets bigger, then you sort of go from moderate to severe. Then when you get like into like this, I mean, this is just, on an unreal amount of work shifting where the patient is essentially doing all the work of breathing. Like the vent is not pressurizing to anything that's appreciable. The patient's pulling flow out of the ventilator essentially without any pressure support, right? Because this pressure, like not to sort of like mix the terminology up, but this pressure that we're driving the flow and volume in is essentially like pressure support, right? It's like pressure support mode or pressure control. It's pressure where the ventilator is providing to set up a gradient for flow to then go on. So when I think of, you could have flow starvation, um, sort of simple flow starvation, meaning the patient just wants more flow or shorter inspiratory time. But if you make that inspiratory time perfect, the patient could still be sort of, it's not so much that they're flow starved. It's when as you termed, sort of like they're support starved. So the flow might be adequate, but they want more pressure. Now
Yeah.
with more pressure comes more volume in a pressure control mode. So if the patient had, you're in volume control, the patient's, let's say the total volume is 450, let's just say, right? And you made the I time very short because you had them on, a zero point 0.9 I time and you recognize that they're flow starved in air quotes, they're flow starved. And you're like, let me go down to zero point 0.7 or something. So the flow is going to be higher. Now you might have taken care of their flow like need, but they still might want more pressure because they want more volume. The question you have to ask yourself is if I switch them to pressure control and I put them on 20/5, so 15 of that like driving pressure, or you call it pressure applied, I think is the term you use, you know, and the flow is going to be based on the patient. I can almost guarantee you they're going to pull more than 450, right? They're going to pull 600. whatever, 650, 600, 700. The question you have to ask yourself is like, is that okay? If that's okay for whatever reason, then maybe they have metabolic acidosis. Like the what I shared last week or 2 weeks ago, whatever it was, the patient with severe metabolic acidosis. I mean, that patient was pulling 750. That mid ventilation was close to 20. That's because the metabolic acidosis was so severe, he needed like a massive MV to keep up with his acid, like to get rid of his acid. So how is 6 cc's going to work in that situation? Like it's not going to work. It's not even going to be close to working. Now you could say, well, you could paralyze him or something, which would be insane because I'm not going to be able to like I can't with normal mechanics as his mechanics were normal because he didn't have any um he didn't have ARDS or anything. You know, with the normal compliance, you're probably not going to be able to if you need a like a superhuman minute ventilation of 20 liters with a 6 cc total volume, even if that's like 500, you're not going to be able to do that with like a normal respiratory rate. Not without auto
Yes.
beeping, not without auto beeping at least, right?
Yeah, it's the
So
magic of the muscles of inspiration and expiration when you have a patient participating that they can crank their respiratory rate and their volumes and work to move in and out in order to actually
right.
achieve them. And then when we go to like positive pressure ventilation and we make them passive, then we are stuck with lung recoil on expiration, and we are limited by just that passive recoil without those muscles. It's so true, and I think that's so often overlooked in the problem of metabolic acidosis. Sorry to sidebar, but that was a good like
Well,
yes,
so
yes.
the problem, right, and the other thing that I want to point out is the only reason why you can have someone on like a 6 cc breath, and so most of the like, do you agree like most of the patients that have bad enough ARDS have some form of acidosis, whether it's respiratory or metabolic from like renal failure, sort of mixed in with everything? The only reason why you can achieve a minute ventilation in the teens is because the compliance is poor, therefore their elastance is high, so they can tolerate a rate of 30 and not auto peep. So oftentimes if someone says to me, I think the patient has ARDS, and I go to the bedside and they can't tolerate a rate of 25, like I'm really thinking to myself like, man, this compliance like isn't as bad as I thought. Like, are we sure this is like an ARDS type lung type situation? Because in the ARDSnet, they say they say you can go up to a rate of 35. I've never gone that high. I've gone to like 32 probably. Like with COVID, we would do like 400 ton of volume at a rate of like 32, which would give you an MV of like 13 or 14, which is like pretty good. I mean, that's like a pretty good mid ventilation, even with acidosis. But the only reason why you can get to a rate of 30 is because the lung compliance is so poor that it's just a rubber band that snaps back, right? So they're not going to auto peep. So if the patient's auto peeping and they think they have ARDS, then usually that's a situation where they have COPD. But if they don't have COPD and they can't tolerate a high rate, I really think to myself like, is this truly ARDS? Like, is compliance really poor? Because if it's poor compliance, you should be able to tolerate a faster rate and like take advantage of that recoil. You know what I'm saying?
Absolutely. I think we could talk all day and all night about like the guidelines that are written numbers on a screen for ARDS and the problems with blanketly applying that across the board to all lung pathologies and not understanding that
Oh, really? Oh, so
like
what you're saying is you don't get the high peep table. The FiO2 is at 100%, and you just make the peep 26 or whatever it is. Are you saying you don't do that? I I I saw somewhere that apparently the FiO2 button and the peep button are the same. So if you're going up on the FiO2, you should just crank the peep and just because like that's how you make it better, right? Is that how it works, or what? Like, what do you think about that?
yeah, it's like again, like we are getting off track, but this could be its own thing because just because ArdsNet is saying a PEEP FiO2, it's a guideline. For me, it is a number in my head saying, I'm probably going to need to go up to a PEEP of X for this patient. But am I
Right.
going to just crank the PEEP to that? Heck no. I'm going to do my incremental PEEP walk up, assessing my lung compliance and resistance, or not resistance, but compliance, and going from there. Like it is. Sorry, my watch is exploding right now. Like there just because a protocol says this is a number does not
Yeah.
mean I'm going to crank it to that. And when it comes to things like PEEP high levels, and when it comes to things like respiratory rates at high levels, like the danger and the downside to just cranking dials is like that's when you can kill someone with a ventilator. Like
So what
it's
so what you're saying is that if you have someone with a sick lung and they're on a PEEP of 5, FiO2 100%, you're and like let's say 6 cc's per kg or something of total volume. You're saying in your mind like we need more than 5 of PEEP, obviously, right? Because like that's just the way this is going. But if you if you just made the so not to get too off topic, but we'll get off topic. That's okay though, because I think this is important. If you just crank the PEEP, right? Like even if the patient's passed, let's say they're paralyzed, we'll make this easy. Patient's paralyzed, they're on 6 cc's, their PaO2 is, 90, they're on 100%, 5 a PEEP, you're picking them up from some like outside hospital or whatever. So someone's going to get them, they're going to say, wow, 5 a PEEP, like what are these guys doing? And they're going to go to 15. So, or let's say 10, let's just say 10, right? If you had a plateau pressure with that total volume of, let's say 28, and you go from 5 to 10, I mean, what's going to happen in that immediate hour, let's say? Like in that hour, what 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 could happen? So what we want to happen, I think we know. But what's the danger with just sort of like saying, wow, they're on a lot of FiO2, I better go up on this PEEP to recruit lung. Like what's the danger in that, I think?
Well, the danger is you might go higher in your plat if you are in a volume, but like I feel like it depends on the mode of ventilation you're in. Like I feel like there's a lot of nuance here with even what you're asking me, because depending on the type of ventilator you're using, the mode of ventilation that you're in, you might be locked at setting your pressures so that increasing your PEEP's just going to potentially change your pressure applied, or it might be your pressure applied or pressure control is set and your PEEP is going to increase it, so you have to walk that down and target lower tidal volume. Like I feel like there's a lot of nuance here. So I don't know how I can truly answer that question. I think it is a not a cookie cutter. And I don't think you can just follow a protocol in every single patient in every single mode of ventilation and expect it to work out. I feel like you have to know your mode, know your weapon, aka your ventilator, understand your mechanics, and then work towards the target of being safe with volumes, safe with pressures, and using PEEP to your advantage if you have recruitable lung and going in a very stepwise approach. So I feel like I dodged that question, but I tried to answer it as best as I could.
No, you're right. I think I think that the like at the end of the day, when you're going to start using PEEP as like a therapy, which is what it is, like in that situation, the most important thing I think is going to be making sure it's safe. Because someone said this at some point, but it takes like hours to recruit lung, but it takes seconds to distend lung. So whether whoever it is, whether it's like a pre-hospital situation or ED or transport or the patient's boarding in the ER coming to the ICU, the way that I sort of look at it is that, when I pick up the vent and start to sort of, play with the settings, I am doing things sort of like low and slow to make sure that I'm safe first. Then when I get the lung to where I want it to be, it's like, how do I support it where it's at? You know what I mean? So it's not just like, that's my biggest issue with the PEEP table is that, let's say it's volume control, right? And you're on a 60 cc total volume and you're at 100%. Let's say the PEEP is 8, we'll just give you 8. And your plateau pressure is 26. In theory, if I double the PEEP, I mean, I'm just adding 8 to the plat until that lung recruits, right? Until it like recruits, which could take time. It doesn't happen automatically. So for some amount of time, that plateau pressure is going to go from 26 to 32 or above 30 certainly. Now down the road, I don't know, 6 hours, like is it going to recruit? It might. And then that plat will come down because you're sort of spreading that total volume over a bigger area over a bigger surface area of the lung. But you don't know that, right? And what if it doesn't? And then what in that 6 hours you're sort of propagating more damage by that increased PEEP. So
Yeah.
the thing that oh God, I hate the PEEP table because I think it's just like not that easy. Like I think it's not that easy. And with the way that the things are going with the ventilator, like we want to personalize the mechanical ventilator, and like the PEEP table is the direct opposite of that. It's the direct opposite of personalized mechanical ventilation. You know what I mean?
Yeah, I think when I approach teaching ventilation, I like to use the PPFiO2 table as a guideline in your brain of just like where your guesstimation of where you might end up. But it's still, if I am making my incremental PEEP titrations and everything is still pointing for me to go beyond that, or if it's telling me to stop, then I'm going to put the brakes or press the gas and keep going depending on what I'm seeing. But it all comes back to like it's that guesstimation in my brain of where I think I might end up having to be. And I might move a little faster for that very beginning stage where if they started at 5 and get them up a little bit quicker to 10 while I'm still maximizing and optimizing everything else to stay safe as the rule. But then like in my mind, I'm thinking I still probably have a ways to go. So I'm going to keep, revisiting this aggressively in the next bit as long as I'm seeing good things to move to where I think I might need to be.